now, any patients in ICU, they have a daily POCUS.
Really?
Yeah. So, and it's amazing, like what you pick up. New free fluid. Like, oh, this cat may be on, it's put on some weight. New fluid, the LAO looks a bit plump. We're getting into fluid overload. We need to like pull back on fluids. Scan the dog, saw one B-line, which can be very normal. So then put the dog in oxygen, said it had aspiration pneumonia because it had maybe 1 or 2 B-lines. Then it had vomited. So I guess, you've got to conserve it vomit. But like the dog was respiratory stable. So then we made an intervention based on the scan, but it didn't need that oxygen. So you have to use it with your history and physical assessment. It does not replace exams. And I love putting a coach on. I've been clapping hands out of the way. My colleagues go to scan before they've even looked at the patient, examined the gums, listened to the heart themselves. They've just gone on with the scanner.
And they need to have their question first.
Exactly.
Hello, Dr. Laura, and welcome to the UAE. Thank you so much for coming over to visit us.
Oh, it's great. Thanks for having me.
And you've come over from the RVC, so that's where I went to college, the Royal Veterinary College in London.
Yeah.
But can you tell me how you came to end up there?
Yeah, so I guess, the Royal Veterinary College, I've been there now, I think maybe over 10 years, was not my undergrad university. So I started off, I was that little girl that wanted to be a vet. And then I did my veterinary degree at Cambridge University and went and worked in general practice, had a lovely time, had a lovely supportive team. And I remember I was a very, really sick cat that I brought back from the dead, really, essentially. It was really poorly and it was a diabetic ketoacidosis. And I decided that ECC was the area that I was interested in. Still was happy to do it in my practice, but just visited the RVC. So there's a big ICU there to get ideas on how to manage the sickest of patients and realised that's where I wanted my career to be. So to go on do specialty training, I did an internship at the Royal Veterinary College. So that's 1 year where you go through different departments. Then I went on and did a residency, which is another 3 years of further training, much to my partner's dismay of just continual learning at the RVC. And then I became a specialist in emergency and critical care. And after about 6 months of locuming, I went back to the RVC as a clinician. And so now I'm a lecturer there in ECC. And, I love my job. I do 70% clinics, 30% research and teaching. And, it's just so nice to be here and sharing what I really, something I really enjoy doing and I feel passionate about.
Amazing. And you are a diplomat, if I'm right in saying, of both the American and European colleges of veterinary emergency and critical care.
Yeah, exactly. So
that's what those letters mean.
Yeah, DACVEC, DECVEC is that's essentially what you get after you've done 3 years of training, and then you have various tasks to do in those 3 years, and then you do some big exams. So
I can imagine.
Yeah, some big exams at the end. So I had to fly to Washington and sit in a room for 2 days doing some quite intense exams. And yeah, so then once you get that, then you get your letters, and yeah, it's just really opened loads of doors for me. And it was a tough 4 years.
Yeah.
Especially being in practice for 4 years where you've kind of been getting into normal life after being a student for so long. Then you go back and it just consumes you for 4 years. But, it's definitely worth it. I wouldn't be where I am now if I hadn't have kind of gone through that.
And it's not just the additional training and the exams that you have to do. There's a research element to being a board certified specialist, isn't it? So what was your areas of research? I'm sure the research hasn't stopped.
Yeah, no.
What are your areas of interest for research?
Yeah, so with regards to the research, you have to have a paper accepted for the American college. For the European college, you need 2 papers. And research is definitely, clinical research is an interest of mine, saying actually what is relevant on the clinic floor. And so I've got kind of 2 main research areas, but generally I get interested and excited about most things. But one is about acute kidney injury.
Okay.
So one of my earliest study I did was looking at hypertension, so high blood pressure in AKI. seeing whether that affected how they did.
And is that just in cats or is that in both species?
Both species, yeah. So my first study was retrospective in cats, and the other one was prospective in dogs. And then now I've actually looking at actual renal recovery after acute kidney injury, which is like super interesting, and whether there's a difference between the etiology of acute kidney injury. So that's one big area that lots of things are happening in the background. I got a grant to look at some aspect of that, which is hopefully pending publication, and then future studies are coming forward on the back of that. So that's kind of one research area. And then the other research area is, and a big teaching area for me, is point of care ultrasound and the utility of that in the emergency room. And so myself and a colleague recently published a paper where we were looking at how good we were on point of care ultrasound are detecting changes, or how should I say, how frequently did we detect changes in cats that they were subsequently diagnosed with urothelial obstruction.
Okay.
So we know that, like, in the last 10 years, that like urothelial obstruction is more common cause of azotemia and even anuria in a cat. But it's a very different management than putting them in a kennel on fluids. Very different management to AKI. And so if we could expedite the diagnosis of that, that'd be amazing, because you wouldn't just sit them in a kennel for 5 days and say, okay, well, their azotemia is not improving. They're not producing any pee. Things aren't looking good. And what I was noticing is when we were point of care scanning, the renal pelvis we were detecting subjective renal pelvic dilation. So just cats sitting, in-sternal, no clipping, putting the probe on their kidney, we were recognizing that. So I said, okay, let's actually look back. So it is a retrospective study. Look back at all the cases that diagnosed urothelial obstruction and how often we reported point of care findings, and how often we reported them in non-obstructed cases. And essentially, we reported renal pelvic dilation much more in urothelial obstruction. And when you looked at us compared to like specialist imaging, if we saw something, it was likely to be significant, i.e., those patients were likely to have a urothelial obstruction. But if we didn't see anything, then it didn't rule out they didn't have one.
I see.
You understand what I mean?
Yep.
So if it was there,
Yep.
then we definitely should expedite getting a proper abdominal ultrasound of that patient. But just because we didn't see anything doesn't mean.
So it's quite specific. Have I got
Yes,
the right around?
exactly. Yeah,
quite
yeah.
specific, but not so sensitive.
Yes.
Okay.
So there's a low risk of false positive. So
Yep.
if we saw something, act on it.
Yep.
But just because you didn't see anything, I can't say.
Don't rule it out.
Exactly.
Got you.
So, and that's quite nice because it merges my kidney interest and my point of care ultrasound interest together, because I really think that changes a patient's management. Like,
let me stop you there and start for any of our listeners who don't know about what you mean by point of care ultrasound, a little bit about what it is.
Yeah, sure. Yeah, so point of care ultrasound is what it says on the tin, really. So you were doing ultrasound at the bedside or at the patient side. You were doing it in whatever position the animal is comfortable in. You work around the patient.
I see.
Big dogs on the floor. They want to be on the floor, wherever they want to be. You're not lying them in lateral
In the kennel, presumably.
Yeah, in the
Get
kennel.
in the kennel and do it there.
Yeah,
Okay.
you wheel. So what you want, and that's probably thinking about equipment for point of care ultrasound.
Okay.
You do not want your fanciest ultrasound machine that's big
and needs to stay in the room that it's in.
Yeah.
Yeah.
Or it doesn't have wheels, or if it's got wheels, it's really difficult to navigate, or it takes ages to turn on. Because I remember in practice, you'd have this ultrasound machine and you'd ages to turn on, and then you have to put all the details in before you can start scanning.
Oh, yes, you do. Yeah, you have to enter all the yeah, you do.
And like, my patient is dying. I don't have time to be like tapping in all these numbers. I don't know all the details yet.
Yep.
But I need information. So you need something portable, durable. It's got high footfall, because essentially I'm using my point of care ultrasound as an extension of my physical exam. So some people now say, it's the new stethoscope.
Okay, so it could go on home visits.
Yeah.
That sort of an idea.
So you can get handheld like ultrasound probes that you just attach to your phone, your iPad, and it's there. And you don't, like I said, you only need the big thing, which I always find there's always limited supply, like wherever you go, is the alcohol or the spirit, because you need to part the fur and apply spirit to increase.
So no clipping.
No clipping.
Okay.
And yeah, we have big fluffy dogs. You just part the fur
All right.
and put the spirit on, and you get good contact.
So you're not moving the probe over the animal the way we would do in a conventional
Yeah,
ultrasound, like thoracic or abdominal
yeah,
ultrasound.
you're doing focused scanning sites.
Okay.
So abdomen, there's 4 focused scanning sites that you put 1, 2, 3, 4, and you look, you fan, you rock, and you rotate. But you're not. When people start going
You're not
off
scanning the
piece,
whole spleen.
no, when they're like,
Junk.
oh, okay, ooh, I'm going falling. No, we're not doing that.
Okay.
It's answering key binary questions such as, is there free fluid? Yes, no.
Okay.
Rather than, oh, what's going on in this intestine? And if you know, when you scan, there's what the left paralumbar site, the spleen is in that view. If you happen to see a splenic lesion, okay, that's interesting.
Yeah.
But and that's relevant. But I don't say I've done a complete abdominal ultrasound.
Okay.
I don't say that I've ruled out it's the same thing as the kidneys.
I see. Yep.
I haven't ruled out a splenic mass. I can just comment if I saw one.
Yep.
And the reason why is this is just in that first 30 minutes when a patient arrives, you're using it alongside.
Everything else you're doing to assess them.
So someone's like placing an IV. You know, a fluid bolus is going in as you're scanning the patient, so it doesn't interfere with your other stabilizing treatments.
How long would it take you to do a POCUS
Well, it
exam?
should take everybody, like, it's within 5 minutes.
Okay.
It's a focus, and this is the thing, is it's focused. And, you know, you have to sort of get out of the mindset of, you know, someone says, try to move the patient on its side or start scanning a bit more. You're like, no, 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 no. What's your question? When you scan, like, what is your question? And your ultrasound is then being used to answer that question.
Okay.
We have started scanning in all our patients because we're a teaching hospital and get people used to it. But you should have a question in mind that your ultrasound is going to help you answer. And in most emergency cases, you can come up with a question that your point of care ultrasound may help you with,
Okay.
such as, you know, oh, it's tachycardic. Could it have free fluid? Could it be hemorrhaging into a body cavity? So you're looking for free fluid in both the chest and the abdomen.
And then that will lead you into what you do next.
Yes.
Do you tap it? Yes or no?
It really expedites diagnosis and management of these unstable patients. Like, it's really like changed how like I manage emergency and critical care patients, and really I think minimized stress for the patient and the people around, because you're not having to move them or go, oh, can you just quickly lie this on its side for x-ray because I really need to know what's going on in its chest. When the cat's really dyspneic, the cat can just sitting in the comfortable position, you know, where it's the way it's maximizing, you know, oxygen,
Yeah.
you know, yeah, FiO2, and while having oxygen, and I can be still getting my information without compromising that cat.
How do your colleagues who specialize in diagnostic imaging, how do they find that? Are you taking away from what they would do? How specialized do you need to be? How comfortable with an ultrasound probe do you need to be before you could start?
Yeah.
You could just pick up
Yeah.
a POCUS probe. Are they called
Yeah.
POCUS probes?
Yeah.
And then start doing that. Start sort of doing your 5 minutes
Yeah.
assessments.
So it's funny to ask about the images, because you've kind of got two groups of images. The kind of more old school images will be like, what are you doing?
Yeah.
Yeah.
Like, you're not qualified to do
Yes.
this.
But now they're really understanding the benefits. And so actually on the renal pelvis, the ureteral obstruction paper, one of my imaging colleagues on the paper with me. And, you know, we're doing more collaborative research, thinking about, you know, images, like reviewing the cine loops. Because this is the thing, is if I give you a bit of background on me, I worked in practice for 4 years, but probably similar to you, where there's a colleague there who really likes ultrasound. So they have like they're the people who do the ultrasound. So I would just give the cases to him and he would scan. And you know what? I do not have the patience to sit and scan and do a full complete abdominal ultrasound.
That's why you're an ECC
Yeah.
specialist.
I do not want their job.
Yeah.
I just know this probe can help me answer some key clinical questions. And so it's kind of conveying to them what we're doing is very different, and it doesn't replace abdominal ultrasound. And, you know, now they ask us, oh, what are you doing about scanning the chest? Because they don't normally scan the chest. But what I'm starting to, you know, realize is I would just pick up a probe and put it on and kind of learn, and someone held my hand on to find what I wanted to find. But myself and some colleagues, we've started up this veterinary emergency and critical care ultrasound interest group. So it's part of the European Society of ECC. So the European Society and College support us in this endeavour, which is amazing. And we're trying to come up with a consensus statement on what is point of care ultrasound.
Okay.
How should we be doing it?
So is there a protocol currently?
So at the moment, there's various, like, if you read the literature, when you read point of care literature, people describe what they've done, but there's no standardization.
Okay.
And there's no, like in human medicine, so we all need to look at our human medicine colleagues. In emergency and critical care human medicine, to do point of care ultrasound, you need to have been certified.
Oh, really?
Yeah. So you need to have been certified to show that you're competent.
Okay.
Okay. So we'd love it if we got to that in veterinary, because we're now at the point where so many people in UK and Europe are using POCUS. And, our interns, for example, are reporting POCUS findings. There's no record of what they've done. They're not saving in loops because it wasn't easy to do.
Right.
Because the machines don't make it easy. But now newer handheld machines, you just literally press a button on your iPad and the image is saved. So how do we quality control that?
Yeah.
How do we say, okay, well, you saw B lines. Are you happy identifying B lines? And, B lines are generally easy to identify, but we are getting to this point where, I said, particularly in Europe, the UK and the rest of Europe, people are using it more. We need to think about, am I calling a spade a spade? Are you calling a spade a spade? And where we are with the VECUS group is this year we're going to develop a consensus where essentially a panel of experts say, this is what we think point of care ultrasound is. This is how what questions point of care ultrasound can answer.
Yep.
And then that will hopefully lead on to coming up with standardization of training.
How soon do you think it would become a day one skill for new graduates?
Oh, well, I hope.
Because I think for me, I would need to go back and I would need to have the training and refresh, and sort of start again. But presumably our new graduates coming out, when they've passed through clinical rotations, they're ready to go.
Yeah. So, and it is, interesting to say that about training the trainer. So people who are qualified, and colleagues of mine who perhaps when they did their residency, point of care ultrasound wasn't a big thing. They openly say, Laura, you need to show me how to do this. And some of the, the students are like a step ahead of, colleagues that have been in practice a while. Why? Because they just weren't exposed to it previously. And so one of my colleagues that work in Calgary in Canada, all of his students are very proficient in ultrasound, but that's Cern Boyson, who's he won't like to say godfather rather than grandfather of point of care ultrasound, but he all his students are so proficient in it because himself and his colleagues, Julie Menard, are that's their area and really focused on it. We've managed to at the RVC get point of care. We now have clinical skills rotation.
Okay.
And they have an hour of point of care ultrasound dedicated.
Okay.
And now I'm working on trying to develop that where we can then put it into assessment. Because I agree with you. I think it needs to be a day one skill. It
would be fantastic to be a day one skill.
Yeah. And now with these new handheld ultrasound probes that are so readily available, it's achievable.
Yeah.
To say it's okay for new graduates or inexperienced people to pick up a probe because it doesn't cost £50,000.
Yeah.
So I think that's the difference, is you really want to ensure that it's accessible for people, and all these companies that are developing point of care ultrasound just making it more accessible for everybody.
I know when I graduated, I was absolutely petrified about being on call and what to do and it's very easy to catastrophize and spiral. So I think if I felt competent using the probe, that's at least, you just need one step. I used to find as a new graduate, and I was like, what's my question?
Yeah.
And then I can answer it. What's my next question? And then I can answer it. And then you start to calm down and you're like, oh, okay, what am I going to do next? I've answered some questions. I've ruled some things off my list, and off I go.
And just thinking about how long does it take you to, I guess competency is one thing, but feel comfortable with something. Just to give you an idea, we had non-clinical students where we gave them a video to teach them how to get a left atrium to aorta ratio.
Okay.
And then they had, not all of them had, because we were doing a study comparing different teaching techniques, but when they had hands-on training for those that did, they only had 10 minutes per person. And the majority of students were then, when we assessed them, were able to achieve, not just find the heart, be able to assess the left atrium to aorta.
In 10 minutes.
10 minutes.
10 minutes training.
Yeah.
That's amazing.
I know. So it's not actually the skill, and that's the heart, actually fanning through the heart to get the LAO. So that's quite a difficult skill.
Yeah.
Compared to putting the scanner on the chest and finding the pleural line and recognizing where you are. Like, it doesn't take long, but if you've never been exposed to it, or you've not had someone standing next to you saying, you're doing it right, or just manipulate your hand like this, then you're never going to feel confident putting the probe on the chest. And, just thinking about the vets that ring me for advice, I'm like, do you have an ultrasound probe? They're like, oh, we do, but I'm not very confident using it. I'm like, put the ultrasound probe on the chest. I was like, you know what colour free fluid is? Black. Put it on, it will give you more information. And so, I do think we need to give training, and we need to be recording like what we're finding. But actually, I don't think it requires a lot of time to train, because I think it's a low bar or like entry to get very important, clinically relevant skill.
It's also very easy to practice.
Yeah.
I've seen the probes that you've bought with you for here, and I'm dying to take one home and have a go on my dog.
Yeah.
And just be like, while she's just lying having a nap, I'm like, to see if I can find this.
Yeah, exactly. And those probes, they're the one that we were talking. They some people with they purchase them for their individual use rather than having to get it for the practice, because they are pretty cost effective. Saying, well, I want that. It's going to be in my pocket and it's going to be mine. And that's what's happening, is that there's a market for handheld probes that, they're not all singing and dancing like the cardiac probe, but they answer key clinical questions that you need in the emergency setting. And what I really like about the handheld probes that attach to your phone or tablet is you can press save, you can press save the still, you can save the cine loop.
And you can add patient's details.
Yeah, then you add patient details
afterwards.
And I do think we should be record keeping if we're making clinical decisions based on these scans. And even more so if we go back to the teaching, an area I'm super interested in is the butterfly probe that I bought this time. Is they use it in human medicine, and they have a platform where you upload your images and then they can be quality assessed. So it's amazing for if I'm just thinking from a teaching perspective, that we can kind of integrate it into teaching institutions where you save that loop and then it automatically goes to my dashboard. Then I look and say, you've said this is a B line. Okay, yeah, I agree that's a B line. Give you feedback. Or no, I would say that, this isn't a B line. This is this because of X, Y, and Z. So it's helping with that competency and quality assurance.
Oh, that's amazing.
Yeah, it's really cool. And so hopefully we're going to utilize a system like that within our teaching institution.
Can I ask you, so thinking from a general practitioner's point of view, cost effectiveness of doing this, how do you charge for the POCUS? Are you charging by time, like blocks of time? Because the other thing I can see that, or I know you've spoken about using it for, is serial or repeated assessment. So that's another way where it comes in handy. If you're, watching a critical care patient over the first 12 hours or 24, have you fully answered those questions, or do you want to check again? Has the situation changed? So how do you... And then if they do subsequently end up still going for more advanced diagnostic imaging, like a CT scan, I can see that from the owner's perspective, why didn't you just send them straight away for... How do you build that into a model that works economically as well as clinically?
Yeah, it's a really good point. And it's something which a lot of times we were just scanning and we weren't really charging, because we would just scan and there wasn't really a charge. You're like, what do you charge? It's not an ultrasound, like, as a point of care.
And
So
lots of general vets will do that when they're learning ultrasound. They will discount the price.
But you have to. But then we were like making, it was really affecting, expediting a lot of the time, diagnostics and management. So you kind of have to charge for time and diagnostic tests. So how we've done it at the RVC is we incorporate it into a bundle, because like you said, serial assessment now, any patient that's in ICU, they have a daily POCUS.
Really?
Yeah. So, and it's amazing, like, what you pick up, new free fluid, like, oh, this cat may be on, oh, it's put on some weight, some new fluid, the LAO looks a bit plump, maybe we're getting into fluid overload, we need to, like, pull back on fluids. So it comes part, like I said, as an extension of your physical exam, so we charge it based on, like, bundles.
Okay.
So the emergency assessment
Includes
includes a POCUS. And then the hospitalization charge, like critical care,
Yep.
includes a POCUS. So it's a bundle package. So the way, and you're right, like, how do you communicate it with an owner? You have to really say, you have to tell them, like, what, because, that itemized bill will probably say point of care ultrasound. And you have to you have to give an indicator of, like, what that is. And someone was, I think it was a delegate that I was working with, had a really nice idea, a way of telling an owner, saying it's like a baby scan. When you scan your baby, you put the probe on, they check the baby. If there's anything on there, then they ask to go and have a bigger scan.
Yep.
So thinking it is, and that's maybe what most people know, someone or themselves have had a child, so they can kind of relate to that. And I quite like that analogy, saying, yeah, it's like I'm doing a baby scan. I'm checking key things. If there's anything on there that it's not complete. So it just signposts you into a certain direction.
I also think that it makes it easier to justify an elevated hospitalization cost, because critical care patients do take more care.
Yeah.
But then I think often owners don't know what that might entail.
Yes.
And it would be very easy to say, well, it's you have a point of care ultrasound, we're scanning these areas to check for these things, which is, sometimes I feel you do have to justify your prices, and this would be a really easy way of doing it.
Yeah.
Understandable way of doing it.
Yeah.
So.
And so, and that's how I think about it, is not as a standalone, because you need your brain and the clinical history of the patient plus your probe. And you need your other diagnostics, like, your minimum database, your blood pressure, your heart rate. You need that information to help incorporate what does those POCUS findings mean.
Yeah.
But when you're starting, we encourage our students and interns to scan everything, because you get used to what's normal.
Do we have sort of indications of free fluid, for example? When do you see differences in breed? Do you see differences in size of dog? Do you have areas where you're like, that's normal amount of free fluid?
Yeah, it's a good.
This is not post-surgical. What's a normal amount of free fluid? When do we worry? When do we action? That sort of research coming.
So there was one publication where they looked at free fluid in healthy dogs and cats.
Okay.
Oh, dogs. I think there was a cat study, but there was I think two abstracts, and one was cats, one was dogs. But the dog one I particularly remember, where they essentially said puppies and kittens are more likely to have free fluid.
Okay.
So, like, and probably because they're just more watery. So 80 to 90% of puppies and kittens had free fluid, whereas like 40 to 50% of adults. But they described it, and it's difficult to know how they did these measurements because it's a 3D structure. They said it was 3 by 3 millimeters.
Okay.
And
area,
yeah, and how I interpret that is
on the screen.
Yeah, it's like, how would they measure? They just did 2D measurements. So I take the actual measurement with a pinch of salt. How I interpret that is, when I scan, if I see fluid that's normally significant, if I take them to abdominal imaging and they've got, linear probes and they're, completely still patients, and they detect a small volume of fusion that they're not comfortable sampling, it's probably not relevant.
Okay.
So I think there is very small amount can be normal. So if I can't tap it easily, and you're surprised to find it, I'd probably just turn a blind eye to it at point zero, just have it at the back of my mind in case I need to go and review. And that's why serial scanning is useful, because you can go back and be like, oh, that's more now. Yes. Now I'm more interested in it.
That's what I probably would immediately think post-surgery. I'd be like, well, I wonder what now, what does it look like 12 hours later or 6 hours later?
Yeah, and the surgery ones are more tricky, because it's how much flush did you put in the abdomen afterwards? How much fluid are they on? Like,
what sort of procedure did you have? Are we worried about septic peritonitis? Is that a possibility?
And even if you had the smallest amount of effusion, if that's septic, then it's surgical. So we do serial point of care ultrasound our post surgical cases, but we look at the whole clinical picture. If the patient is stable, its heart rate's normal, everything's trending in the right direction, normothermic, eating, I just watch. But if it starts to have some changes in its heart rate, or temperature's going up, we start to regurgitate a bit more, we may look a little bit more, and then we use our ultrasound to get an ultrasound guided or sample.
Thinking of all the sort of surgeries where you remove a foreign body, for example, and the first 12 hours are a bit rocky. I think, again, it would be really good way of at least relieving your mind.
Yeah.
You've done the surgery in the middle of the night.
I know.
Oh, I just want to have a look before I try and go home and get some sleep, or hand over to someone. And I was like, this is what it looked like now. I can see that would be a real benefit.
Yeah, we do like it's nice then you've got the continuity of care if the same person's scanning.
Does the same person need to be the one scanning?
This is why I think it's good to record cine loops.
Okay.
Because I say, oh, it's got a small volume of fusion. You say it's got a large volume of fusion.
Yeah. What do we mean?
Yeah, what do we mean? So I really encourage, especially when we have residents who do Monday to Thursday ICU, and then the other person does Friday to Sunday. So I'm like, you need to record this loop so that then when blah 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 takes over, they know what you mean.
What you've been happy with all week.
Yeah.
For example, they know what that looks like.
Yeah, exactly.
Makes sense. Are there limitations to POCUS, and what are they? Because presumably it's important to know those.
Yes.
Who is using it?
No, it's I want to actually do a lecture, Pitfalls in POCUS, because it's so, I know I love a bit of alliteration, but yeah, it's what happens is when you use the probe and don't use your brain, and you think the machine is cleverer than you.
Okay.
And I really liked it. There was a sticker. I went to a tea plantation in Sri Lanka, and there was a sticker on one of the machines that said, "This machine doesn't have a brain, so use yours." And what happens is, we as I said, in my institution in the UK, in Europe, lots of people are scanning, and we have a dog that comes in and they weren't concerned about its breathing rate or effort, completely normal. But they scan, this is what happened to one of our colleagues in my work, scanned the dog, saw one beeline, which can be very normal. So then put the dog in oxygen and, said it had aspiration pneumonia because it had maybe one or two beelines. And like, but you won't. It had vomited, so I guess you've got a concern about vomit. But like the dog was respiratory stable, so then we made an intervention based on the scan, but it didn't need that oxygen.
Yeah.
So you have to use it with your history and physical assessment. It does not replace a physical exam. So I've been like, and I love point of care ultrasound. I've been slapping hands out of the way of my colleagues who go to scan before they've even looked at the patient, examined the gums, listened to the heart themselves. They've just gone on with the scanner.
And they need to have their question first.
Exactly.
Before they pick up their probe. You
have to have a clinical question because it is there to answer a binary question. Yes, no. And then sometimes the other thing is people start going off piste and then, going, oh, we're looking down here. And you're like, no. Because then now you're halfway house.
Yep.
You're not doing a POCUS. You're doing a bad abdominal ultrasound.
Yeah. So now you need to refer to someone that's where you hand over. Yeah.
Yeah. And I think maybe the reason why I'm so fixed on that is because I'm not a cardiologist. I'm not an imager. I don't have the patience for either of those. So I don't go off piste because I'm not trying to do more. I know when to stop because I'm saying, no, I've answered my clinical question, move on.
Okay. Perfect. Makes sense.
And I've got a nice slide in sort of my lectures where there's the latest consensus on like feline cardiomyopathies, and it's actually got POCUS as one of the qualitative assessments, saying here you go, you can use point of care ultrasound to assess qualitatively, so all subjective rather than measurements.
Okay.
So don't get bogged down with measurements. And then there's a whole list of the things that you look for on an echo when assessing a cat with HCM, and looking at our point of care cine loops compared to echo with all their colors and their fancy flows, they're very different. And just really highlighting that what I need to answer the clinical question in the emergency room is the cause of my dyspnea congestive heart failure?
Yes or no?
Exactly. Yes or no. And then that's it. And if I say it is, then I would recommend, and maybe some owners say, well, I don't want to, if you've got a cavity, for example, and it's like probably going to be mitral valve disease, I would say, I've answered that question. I recommend you have a cardiologist review to, confirm that and help you with the long-term management. Mine's all short-term management.
Of course. moving away from POCUS, I wanted to ask you a little bit about a topic that I've heard about from the RVC podcast and I'm very interested in, which is xenotransfusion. I know another area of your interest is transfusion medicine.
Yeah.
When I graduated, I think xenotransfusion, it was just you don't do it.
Yeah.
It's too risky. It's too dangerous. There's no clinical protocol for doing it. There's no justification for doing it. It's reckless. That thought process has clearly changed. Where are we now?
Yeah. So I think about xenotransfusion, and so for those that don't know what that is, xeno is essentially giving blood of one species to another species. And yeah, it's really been interesting because I've been at the RVC now over 10 years, seeing the evolution of xenotransfusion practice. And, in the UK, so in the US, they have like colony of cats that they can like bleed. Like they have a colony of cats that are kind of blood donors. And so some of our US colleagues can't always get their head round why.
The ethics of
Yeah, exactly.
To a certain extent.
Yeah, we would not be allowed that in the UK to have a colony of cats.
Sedated to do that.
Just so it's interesting for our blood donors, we don't sedate them; they're all owned. Yeah, it's honestly our transfusion centre is so beautiful. We've got dedicated transfusion nurses, and they do a beautiful job. My cat went to be a blood donor, but he unfortunately had heart disease, so he couldn't be. So they do, yeah, their feline practice how they do it. They don't actually
Oh wow.
Yeah, and it's beautiful. But so thinking about in the UK, you would not get away with having a colony of cats that were just there to bleed from when you needed it. And I think maybe when we graduated, do you remember oxyglobin?
I do.
Yes.
I do.
So oxyglobin was the fake blood.
Yeah, expensive, but
Yeah, but it had a long shelf life. I remember I used it once in a cat, and so you had the kind of fake blood that you could give a cat. That that went out, or we couldn't get hold of it. So I remember when I was a resident having a cat that was anemic, and we had no cat blood, and I had to like sit watching this cat deteriorate because I couldn't give what it needed. And that was heartbreaking. And since then, we were like, okay, what do we do in this situation? We can't get like, synthetic blood product. We know the patient needs blood. And so then we looked up like xenotransfusion. There were some publications of xenotransfusion in CPR, for example, and we used to have a protocol that was like, okay, if you think the patient is going to die in the next 6 hours, because it was like risk benefit analysis, then you can give them xenotransfusion. And now actually involved even further because there's been many more publications on xenotransfusion. And there's important things we need to know about xenotransfusion because we give them more readily now because there's a scarcity of feline blood. It's not, so just maybe to take a step back. So we have cat donors that are client owned. And now we never used to, we store cat blood. So we have the right size bags that we can store cat blood. But, thinking about the size of a dog, how much blood that dog can donate versus one cat, how much they can donate, we just can't keep up with the demand.
And can you separate cat blood the way you would separate dog blood into, or is it too small a volume?
Yeah, it's probably too small of a volume.
So
like
it's normally stored as whole blood.
Yeah. Oh no, sorry, we do packed red blood cell units. Sorry, I thought you meant splitting units. No, we do spin it down to packed red blood cells. Yep. So we have packed red blood cells stored, which is great. So now we can actually go to the fridge and we can say, well, we've got cat blood in the fridge. You don't have to go and get the cat in as needed. But still, we don't have enough cat blood. And so the thing with the xenotransfusion is it's really used in emergency, particularly useful for hemorrhage, because you really need to patch the cat up until it starts regenerating.
In a trauma case.
Yeah, in a trauma case. So you patch the cat up, give it blood until its bone marrow kicks in to regenerate the red blood cells it's lost. And the thing with the xenotransfusion, it has to be informed consent. You have to tell an owner, do what you give me permission to give dog blood to your cat. Why? Because we don't have enough cat blood and your cat really is showing signs that its hemoglobin, its red blood cells, is a critically low level. If we give this, we are giving a foreign product to your cat. Now, in my clinical practice, and we've given a lot of xenotransfusions, they don't usually react while you're giving it.
Okay.
Because they don't have antibodies to the foreign substance yet, but they will react to it.
Yep.
They will start breaking it down. They'll start realizing, hang on a minute, you're not my red blood cells or anything like my red blood cells. So they do hemolyze the transfusion. And normally we say within like 2 days, the PCV will go back to where it was before, or even lower, if the bone marrow hasn't regenerated.
Of course, yep.
So when we give a xenotransfusion, we always have to be ready saying, right, that buys us time to get cat blood in. And if there are some cases we don't need to follow up with cat blood, but they are the ones that have had maybe a xeno during surgery with a pelvis repair or something. Mm-hmm. But we don't know for definite that they're not going to need cat blood because we don't know how much they hemolyze versus how much their bone marrow is regenerating. So I'd always plan for cat blood if you can. And the other really big thing is you can never give that cat dog blood again.
Yep, it's a one time.
Because it's now got the antibodies and it will, touch wood, never, our clients, we are very aware that we've got very good record keeping. Our clients are fully aware they've had cat blood, dog blood before. We did my colleagues did a study where they assessed how well the owners remembered, and they remembered pretty well that their cat had dog blood, because they can never have it again, because then that would be catastrophic for them to the reaction they would have. So I think it's been really important. Yeah, it's difficult to get your head round when someone first says it to you, and probably difficult for owners to understand. But we've saved so many cats' lives by giving them dog blood. But you have to monitor them, like any transfusion.
Yeah.
You monitor them like any transfusion, and then particularly afterwards, you be ready for them to hemolyze. And when they hemolyze, the bilirubin goes up. Okay. And it jumps. It can go from like 10 to 400 because it's a massive hemolysis. They can feel not great with it, and we have to watch their kidney function.
I was going to say, do you have to test that before? Would mild azotemia be a reason to rule out? Does it depend on the reason for the azotemia? If it's
so we know that bilirubin can cause, and it's an area of interest, like looking at it's me particularly looking at acute kidney injury after xenotransfusion. But the data we have so far, it's not like overwhelmingly they do, but we may not be very good at detecting low level, like, or early grades of acute kidney injury. But we need to think about it's a life-saving treatment. It's not like, oh, it's a little bit anemic, let's give it a xeno. No, it's like this cat is clinical for its anemia. So then and the kidneys may be suffering because they're not getting enough oxygen delivery to them because there's not enough red blood cells. So an azotemia would not stop me giving a xeno because the need for blood, the patient that we're doing it in, the need for blood outweighs maybe your kidneys are like struggling for some reason. But we do have to monitor for their jump in bilirubin and their kidney function afterwards.
Because what do you do about fluid therapy when you're worried about you've given blood, you don't want to dilute the blood that you've given, you don't want to volume overload the animal, but you want to try and protect the kidneys?
Yeah, so we normally when they have their transfusion, so it's another interesting point about dog blood is that dog blood comes in a unit. So you're not giving the whole dog unit.
Obviously.
You have to kind of really calculate how much, blood you want to eat. There's volume overload is a risk in anemic patients that then you're giving a large volume to. So we don't give them crystalloid fluids during their transfusion. So they have their transfusion, and a lot of the time in all transfusions, we give in syringes. So each syringe, so blood can only be out for 4 hours. So we just put it into aliquots of syringes. So I actually gave a cat the other day, blood over 14 hours because I had this syringe in 4 hours, this syringe in 4 hours, this syringe in 4 hours, because it was at a risk of overload. As long as each syringe was only out for 4 hours, then we could give it more slowly. And then we just, they go back to what their normal therapies were afterwards. So if it was on fluid therapy or we want to put it on fluid therapy or crystalloids, it can be.
Good. Amazing. My last question that I ask all of our guests is, what 3 tips would you tell our veterinary community, mostly in general practice, some specialists here, but what 3 ECC tips would you like every vet everywhere to know?
Wow, what 3 tips? So first of all, I would say use your eyes and your ears. So just watch your patient. So you can gain a lot just by looking at them, particularly and listening. So hearing what the noises they're making, what their chest is doing, how they're holding their position, can they stand? You know, I really think you can get a lot just by looking at a patient. Think of a ultrasound as an extension of your physical exam. Like I would just love to everybody to have a handheld ultrasound in their pocket that they just get out in as part of their extension of their physical exam. Then the other thing I would say is use your team because, emergency and critical care, it's a team game. Like, yes, you're scanning, but, your nursing team are going to be there placing the IV, getting oxygen, getting the fluid therapy for you. Like, everything is happening together. And I find, I've got very good at delegation in the emergency room because you are there, your brain is thinking about everything that's going on with this patient. And then you need to use your team and use them to play to their strengths to optimize the care of the patient. So, yep. And then, putting that all together is the machine has no brain, so use your own.
Your brain. One final question as well. So from my time in the RVC, I remember the ECC room was not huge and they were just lined with kennels all sort of around the outside, and it felt like you were spinning, like when you were a student, that you would just spin round and watch them. Is it still like that, or have things moved on in the years since I've left? Do you have more space?
Yes. So we have now ER and ICU are separate.
Wow. Okay.
We've got a big ICU. We've got lots of cool oxygen kennels, like humidity and lighting. So they've got like great lighting for like the mood of the cat.
Nice.
Yeah, it's really nice. We don't have a separate cat and dog ICU yet, but yeah, it's a big room. We've got great ECG monitoring. But yeah, probably I'm trying to think about sizes. It's a big space and big team. Like we've got a lot of amazing nurses, amazing vets, and yeah, students. I told you, we've got 300 students now.
That's crazy. That's double what was there when I was there.
Yeah, I know.
So where do they all go?
They are a very helpful pair of hands.
Yeah. But there's a lot of people in one area with ECC, and I was like, how do you must be the sort of personality that thrives in that chaos. I'm not sure that I would be. I think I like a bit more order and a bit more, like I like my patients to behave themselves a bit more than ECC where they don't, and things can change.
Yeah, like that. And it's just teams, and it's just amazing when you get a good team and everyone comes together. Like the big thing is, when you have a CPA, so like cardiopulmonary arrest, and someone presses the crash button, and I'm not joking,
it's petrifying.
Practically the half of the hospital come to ICU. And there was one time I'm leading this arrest, and I look around, there's a sea of people, and the team, and that's why I was thinking about the kind of knowing your team and using your team, because it's amazing how well a team can come together and just do so many days at the end of my shift. I'm like, yeah, we did well today. Yeah, do you know what I mean? We were, and not me either. Well, no, I could not have done it without the team that I have with me, and particularly the critical care nurses that I've worked with, over 10 years. They taught me so much, and that's maybe my other tip is you can learn something from everybody. Just because I've got all these letters after my name doesn't mean that I know everything. I pick up stuff from people, talking to you, talking to your colleagues here. You pick up stuff from everybody, and I think just keep willing to learn and be receptive to what people have to say. Because
and be receptive to change.
Yeah.
To adjust something just because that's how you've always done it doesn't mean
that's
the best way of doing it.
And sometimes that's people's knee-jerk reaction is, oh no, I don't like that because that's not the way I did it. And that's okay. But just check yourself and say, okay, that was a knee-jerk reaction.
Yeah.
wait a minute, let's reconsider this from a different perspective. And in say maybe I remember when I got resistance to point of care ultrasound trying to put it into the teaching curriculum, and people above me would be like, "What? Like, no, we don't. I don't need that." And then I'm just like if you're the other end and you want to make change, just keep tapping, because now fast forward 3 years, I'm creating this way of assessing point of care ultrasound. And I found a document that I created like 3 years ago that kind of like fell on deaf ears. And I was like, oh, I created this 3 years ago.
Do you think that's because those ears were specialist ears? Because I think if you were talking to a group of GP vets, they would very quickly say, yeah, I can see the benefit to that, like for everybody. So
There's,
for a new graduate.
yeah.
Whereas I don't know, perhaps a specialist, I don't know, that might be too
Boy,
fair.
some
They've
people like,
become a bit set in their ways and I know how to do that, so I don't need to. Whereas,
I think people who particularly like X-ray struggle
okay,
because they're like, well, no, like X-ray, that's what I'm used to doing. That's what I can interpret.
okay, that would make sense. I
Yeah.
just hate X-rays.
Yeah, me too.
And there's a lot of AI moving into X-rays now, which I'm.
Oh, I've got a good story about an AI X-ray.
Yeah, there's a lot of limitations there. I think it can be useful, but it frightens me quite a
Oh,
bit as well.
yeah. I mean, my joke to the images, because it's my last anecdote, and then we'll finish. But we had a case referred in. The AI said it had a lung mass
Okay.
because it just this little scale thing.
Yeah.
And I looked at the X-ray and the point of care ultrasound and the clinical history, and I was like, I think it's got aspiration pneumonia. But I'm like, me versus AI. So then I go to our images and I'm like, what do you think? And they're like, I think aspiration pneumonia. And I'm like, oh. And then I think we did a CT because they were referred for a lung mass. And we're like, we have to be really sure that this is not a lung mass. So it had X-rays, CT, aspiration pneumonia. And so I was like,
How did it not have symptoms of aspiration? Yeah.
yeah, I mean, that's what I mean. That's what use the history in the physical exam.
The AI is only a tool.
Yeah, the AI is a tool. And I think it can be like you can work with it, but like not using it completely. So yeah, we ended up going to CT because we both were like, well, it's just our word against AI. And so afterwards, I remember like high-fiving the imager, being like, job's not taken yet.
Yes, exactly. You still need a human brain to interpret what you're finding, which is reassuring.
And that's why the other thing,
Reassuring.
when you use like teleradiology or like CT, colleagues of mine who do that, they don't. You have to give them the history. You have to give them a physical assessment, and because they're, they're interpreting X
Half the
doesn't.
picture.
Yeah.
Yeah.
And we talked about it with like lungworm, and I was like, oh, can you just see whether that's hemorrhage or pneumonia on CT? And they're like, no, actually, we can't differentiate between that. Like you have to. It's only create lists as differentials, which you as the clinician should have an overarching view on the case, then put the piece of the puzzle together.
Yeah, of course. So on that note, robots are not going to take our jobs just yet.
Not yet, no.
Well, thank you very much, Dr. Laura, for joining us today and also for touring the UAE with us to the university, to Abu Dhabi, and then for our big CPD event. But thank you very much for joining us and for sharing your wisdom. And we hope you have a lovely rest of the stay while you're here.
Thanks so much for having me.